Don't let my residents ever hear this.
It gets your mojo going.
It does. It's fun.
Probably be big rimping.
It's a safe place here. We're in the trust tree. I use inhaled sildenafil.
We're smoking like a round beer.
Yes, we are.
Actually, lucitropy is a thing.
Hello and welcome to Echoholics Anonymous. My name is Jimmy Fair and I am an echoholic.
And my name is Brian Galovic, and I'm an echoholic.
And I am Josh Zimmerman, and I am an echoholic.
The echoholic, some might say.
I wouldn't say that.
So, Brian and myself, Jimmy, are emergency physicians, and we're lucky to be talking with Josh Zimmerman, wizard of all things echo, here at the University of Utah. He runs an echo fellowship, as well as kind of co-runs an echo lab. Is that about right?
I think you can say that. Dave's not here to argue with me, so yeah.
So, what is Echoholics Anonymous? Well, it is a podcast devoted to echo with a little bit of beer thrown in. And why not combine two things that you're passionate about?
I agree.
Amen.
Specifically in echo, we're interested in point-of-care ultrasound that can inform your care right at the bedside.
And point-of-care beer.
And point-of-care
beer that can improve your life immediately at the bedside.
At the point of consumption. So, as part of the Echoholics Anonymous podcast, we have two segments, and we're going to start off with the segment that's about beer, which is the bubble study. So, for this bubble study, we have Echt Schlenkerla Rauchbier. Before we dig into this, we should be able to pronounce the beer correctly, right? So, if you go to the German Beer Advisor website, they instruct you on how to pronounce this beer. Josh, did you want to take us through this?
I'll take you through my first experience with this, where I looked at the phrase "like X in Mexico," where the country's name is pronounced by a native speaker. I'll spare you the exact language I used when I read this. And for those of you that don't know, my name is actually Dr. Von Zimmerman. It's true. It is. My
you have
family
a Von
is
in there?
I do. I could
know.
technically use the Von if I chose to.
I did not know that.
Nonetheless, I do not pronounce this as if the X in Mexico were. I don't even know what that means.
All right. So specifically, out of the Rauchbiers, which are a smoky beer, we're tasting the Urbach. Out of all their varietals there at Echt Schlenkerla is their seasonal Oktoberfest beer. So Brian, do you want to tell us a little bit about what an Urbach is amongst the Rauch beers? What makes a Rauch beer and what makes it an Urbach?
Yes, I'll back up and start by talking just a little bit about Rauch beer. And Rauch beer in general is beer that uses smoked malts. And I think if you translate the German, it means smoke beer. I don't speak German, so I'm taking that at secondhand, but I believe that is the case. And a Bock would then be a different style of beer, typically produced in Germany as well. I believe it was a Munich beer originally, and it tends to be characterized by a little bit heavier alcohol content and more of a sweeter, maltier profile. So if you combine the two, if you have a Rauch beer that's an Urbach, which I believe means true Bock, it's a sweeter, maltier smoke beer. And so the origins of Rauch beer date back a long way. There are some stories out that say that sort of in a very dramatized fashion that a cloister burned down with its contents, including its barley, and in total the only thing left was some of the barley with a heavier smoke quality then. And so to not let it go to waste, it was used to make beer, and it ended up having a very smoky quality. But in reality, the truth is probably that kilns in earlier days were not as successful at preventing smoke from getting into the actual malting process, that drying out process, to dry out germinating barley. And so you probably had smoke getting into barley at all times. So most beers probably had some component of Rauch to them initially, and that's really carried over as a traditional style in this area in Germany.
So this particular beer, the Echt Schlenkerla, is supposed to be the original brewery of the Rauch beer. So now it's time to taste this Rauch beer. So gentlemen, cheers.
Cheers, guys.
The smoke comes through.
The aroma is very smoky.
Yeah, I would agree. And reddish,
really
maybe.
Dark. Yeah.
So it's a dark beer. It's got a lot of smoky notes. Yeah, and I mean, you can tell just from looking at the beer that it's got some dark aspects, right? It's brown to black beer, right? People will quote all sorts of flavors in the tasting profile for these beers, everything from toffees, caramel notes, all the way through strong chocolates, coffee flavors, roasted flavors.
It does have a sweetness to it for sure.
Mm-hmm. And that's fairly typical of Bach's.
I'll tell you guys, as somebody with very little experience tasting or describing or thinking about beers, but with an enormous enthusiasm for alcohol of all other sorts, I was really surprised by this. I expected this to be, I thought this was going to be less accessible.
Yeah.
Like this, when someone describes this, you're like, oh, this is a beer for experts. I'm going to be way in over my head, but it really seems it's more well balanced than I expected. The body is lighter. The flavor itself is well balanced. The smoke is really present, but it's not overpowering. Anything with an overpoweringly smoky flavor just winds up being smoky sort of for its own sake, and this doesn't taste like that.
It kind of lingers on the back.
Exactly.
End
The
to
finish
get
of this is really
smokiness,
nice, but it's smooth.
No, it's a great beer. And I think you notice the more you drink it, the less that smoke flavor comes through, and other portions of the beer start to open up. And that's true as the temperature changes. The longer it sits in our glass and warms, you're going to start noticing other flavors as well.
So is it an actual change? Is it like is the smoke a volatile flavor, or is it just a change in our palate sense, do you think?
It's actually really kind of an interesting thing. So if I do some brewing as well, in addition to just drinking beer, and one of the things you note if you've made Rauch beer is the first time you do it, the smoke quality of the beer you make isn't that strong. And a lot of what you'll find then is if you reuse that yeast, it carries the smoke flavor with it. So this brewery and a lot of brewers in particular will maintain their yeast strains when they're making Rauch beer, and the smoke flavor is somehow maintained by the yeast. And honestly, I haven't seen a good explanation for why that may be, what sort of chemical composition is producing this taste that we experience, but it must be in some way propagated, and that's very cool.
Could it be magic?
Or it could be magic.
Okay.
Maybe magic's a possibility.
Okay. Well, I want to congratulate Brian on a great choice. When I saw this and read that description, I was not enthused. Now, I am actually way ahead in the consumption of our first beer. I feel pretty proud.
I hope that you listeners can try some of this at home. Pause, go to your liquor store, find some Rauch beer, and then join us for the next segment, which is the Echo segment.
Today, we have an Echo brought to us by Josh Zimmerman. And it's a really interesting case. I think it's pretty fascinating. It brings up a lot of relevant issues in point of care ultrasound.
Until my next case.
Let's set the stage real quickly. This patient came into the emergency department with chest pain.
Well,
right?
yeah. The way this works is he presents to you, then he presents to me. In
Exactly.
a sense,
Yeah. And so let's go ahead and present it kind of as it happened. So the day before Josh sees him, he comes to the emergency department with chest pain, and he's a late 50s, early 60s age guy who has an EKG like this, and it's pretty much a no-brainer. This guy goes to the cath lab. So here we see that they've obviously placed a stent in the right coronary artery. Later that day, he ends up in the ICU. They get a transthoracic echo. We can see enough to know that the right ventricle seems to be pumping okay. We see grossly the TAPSE looks to be probably normal. And certainly the right heart doesn't look enlarged compared to the left heart.
And beyond that, just looking at the LV, you can comment potentially on the inferoseptum from this view, which could potentially be implicated in an RCA distribution infarct. And it's hard to make any huge claims here, but we're not seeing any gross abnormalities that would raise alarms looking at this study.
So the patient's in the ICU. Josh is out preparing dinner.
Yeah, so the way this part of the story goes down is he has part of his most immediate occlusion revascularized in the cath lab, but then comes back later on to the operating room now with his RCA stent in place. Now he's cooled off, he's been stabilized, and actually we're in the ICU now after having spent hours in the operating room with a cabbage, and everything goes great, just like you would hope it would.
And so you get the call while you're back at home, and you show up, and what's the clinical scenario that they give you?
I'm there with one of our critical care physicians who I respect very highly, along with our surgeon who I respect as well. And we are placing the echo probe with this patient who really has been surprisingly hypotensive, somewhat resistant to our usual sort of ICU post-op interventions.
Okay, and so you place the TEE probe. This is what you see next. Is that about right?
That's about right, exactly. So I put the probe in, look at the monitor, look back at the machine, and then...
Dun, dun, dun.
Exactly. So the patient then goes from being hypotensive to being pulseless.
And how would you characterize this rhythm if you were looking at it on the monitor?
Well, I was looking at the echo, so I didn't need to characterize it. I knew what was happening, as you will when you see this image. But everyone else in the room was looking at the monitor.
And they were telling you what?
This is PEA.
Right. But you were telling them.
This is not PEA. So what we see here is a patient who, as they often are after cardiac surgery, is being paced. And we can see the pacer spikes on the screen. And those pacer spikes, and this is not the first time I've seen this. It's a real issue, and it doesn't usually cause long delays, but can cause short delays in treatment because it looks like organized electrical activity. It's regular.
Echocardiographically, are you calling this VTAC likely, or
I would say
VFib/VTAC?
This to me looks like VTAC.
Yeah.
There's a very organized appearance. There's a regular. This is a long clip.
Seems to be very rhythmic.
It does. Yeah. It's conceivable that it could be VFib. Usually VFib isn't this regular and it isn't this brisk.
Exactly. And some people describe VFib as being kind of a bag of worms appearance, whereas this seems much more rhythmic than a worm, I guess.
Yeah, you can imagine this was a heart rate of 300. It looks like there may be a rate under there. There's just no ejection.
And so, of course, this is a transesophageal echo. So we're looking out of the left atrium, which is here. Here's the left ventricle, which has that rhythmic contraction. And we're seeing a right atrium and right ventricle that appear to be large, right?
Yeah, that was one of the interesting questions. You know, when you look at somebody's heart who's in a malignant ventricular rhythm, you're not really expecting to make that's a pretty good diagnosis to make. You know, you're not necessarily hoping to make other diagnoses, but even still, you look at this and you're like, I think I know what's going on here. I think I see the problem.
Very interesting. So let's see what we found next. You're in a transgastric view here, right? So we're looking out of the stomach at the left ventricle mainly in a cross section. And how would you describe this, Josh?
Well, this is another malignant ventricular rhythm, but this patient's been shocked now probably and has come back and forth a couple of times. And what we see now is another VTAC. But now you can see why some VTAC is not pulseless. It's fast. It's too fast. It's not great, but this ventricle is ejecting. You know, this is a pressure that's low, but not none.
Yeah, it definitely looks like it's moving there.
Yeah.
It's in a concerted fashion in a way.
And so I take it you probably shocked him at this point again, and then you get something like this.
Yeah. This is another one. Yeah, this is another one of those rhythms. And now you can see the distinction between this one and the previous two. This is the appearance of VFib. This is Jimmy's bag of worms. One of the things that we often, and you guys think about this a lot, like this is not the same thing as cardiac standstill. You know?
No, definitely not.
That's something that I think we all need to keep, pay attention to and look at a lot. You know? When do we go from VFib that may be susceptible to a shock to then cardiac standstill? And it's a progression, you know?
Absolutely.
Yeah, these images I think are a real caution to anyone who's determining rhythms solely based off of pulse check and their telemetry leads, right? Because we know that both of those things are pretty fallible.
And there's data to support that as well. Yeah.
Hey listeners, Jimmy here. Sorry to interrupt, but while we were on the topic of the fallibility of pulse checks as well as telemetry interpretation, I just thought I'd highlight this interesting article out of Resuscitation, the Field Protocol Focused Echo Evaluation in Life Support. This study was very interesting in that it was emergency doctors responding in a pre-hospital environment with transthoracic echocardiography in patients who had cardiac arrest or a shock state. What they found was that in 35% of those patients that they thought had asystole, they actually had coordinated cardiac contractility. And in the majority of cases where they thought the diagnosis was PEA, there was actually coordinated cardiac contractility as well. We will throw a link to this study as well as some other literature on the topic that might be of interest to you up on the website. Now back to the podcast.
So then some of this happens, right?
Yeah, you know, Jimmy, I'll let you comment on this because I actually took this image because of the discussions that you have had with me about how I should be using TEE to help guide chest compressions. That's not something that I've really spent much time thinking about in any organized fashion.
That's flattering. I would say that maybe you'd want to be in a long axis view though, because you could see whether you were compressing the aorta.
And in my defense, there are over 200 images from this study, only some of which we're showing here. And but honestly, like I actually, as a result of our discussions in that article you just recently tweeted, I actually took those images, looking at the LVOT, thinking, hey, because the truth is, I wasn't running the code.
Yeah.
I had a critical care doc and a cardiac surgeon and a bunch of nurses. I just was there. I mean, it's not fun. I don't want my fellow man to suffer, but I was just there to take pictures. And so I could be like, hey, I wonder what's happening in the LVOT. Wonder what Jimmy would say about this.
Like a wartime photographer. You're just there to document.
Yeah.
That's exactly right.
So got some compressions and then seemed to do better after that, yeah? Recovered a little bit of function here.
That's right. So now this is actually, and this is an organized rhythm, right? We can see the difference between this and the previous one. And obviously we have good LV ejection, but...
Why don't you take us through this image, Josh? And
right. So when I look at a 4-chamber image, I start at the top. Actually, you know what? For almost all of my images, I start at the top where the probe is, and I move clockwise.
Okay.
So I start at the left atrium. I see the interatrial septum. I see its bidirectional excursion, which gives me a sense of not the absolute, but the relative pressure in the chambers. If there's bidirectional excursion of the interatrial septum, it suggests that the pressures are relatively equal. One is not much higher than the other. They could both be low, both be high. But that is a useful piece of information, and it pertains to this particular discussion as well.
Tends to bow towards the
It
LA,
does tend to bow toward the
Yeah.
LA, exactly. So we know they're probably not quite equal. Mitral valve looks okay. It's opening quite well. Bristly has, if we were to assess the E-point septal separation in this image, it would be just fine. There's not been, and when somebody's had brisk chest compressions, we can do all kinds of bad things to them. And I've seen all of those things. That mitral valve doesn't look like it's been disrupted. That stuff happens. The LV actually has, now this patient is, I will tell you, on ripping doses of vasopressors and inotropes. And so, yeah, this isn't a normal ventricle underneath all of that, but right now, this guy's not dying because of his LV. As we move around here, what we see is our right side of the heart, and now we're not so happy. Whether or not I had seen the images from this guy's case previously, which I had, and knew that his RV had previously been normal, as you saw, this is not how an RV should look. Now, we don't see the entire free wall of the right ventricle. We see the basal half, basically. We see the tricuspid annulus. We see the RV free wall at the base. We don't quite see the apex, although we get the sense that the apex of the RV, there's maybe a little bit of activity hiding down there somewhere.
McConnell's?
Could it be? Well, I in jest suggested this to one of my colleagues who said, indeed, this does appear to be a McConnell sign. And it is in fact a McConnell sign.
And what is the sort of the technical designation of a McConnell sign, if you will?
So Dr. McConnell, in his, I would say, really influential, very important study, showed a strong association between a particular echo finding and massive PE, large PE, significant PE. And that was an akinetic free wall of the RV with relative sparing of the apex. So little activity of the RV apex, but really akinetic or massively hypokinetic right ventricular free wall. And he showed a very strong association between that finding and PE. And now it won't go away.
So what we know now about McConnell's sign is that it is not quite as specific for pulmonary embolism as we once thought.
So can you think of any relevant echocardiographic findings that might suggest to you that what you're looking at would be a PE or an RV infarct?
So I think that's the key question. Is this a massive PE, which could happen, or is this an RV infarct or severe RV ischemia of some sort?
Is there anything else that causes a McConnell's mimic?
I don't know.
A McMimicker.
If you know other important McMimickers, you should probably enlighten us.
Well, I've seen ARDS cause
Really?
acute RV strain that looks
mimicked
very
a
much
McConnell
like a
sign.
McConnell sign.
And I guess that kind of hints at what would be the sort of the cause for
Right.
McConnell sign. So
Yes.
in this setting, right, presumably, I don't know if we're giving it away at this point, but presumably
We're all friends
you have an
here.
RCA territory infarct, and the apex of the right ventricle, as it's portrayed here, would typically be supplied by the LAD as it becomes dominant around the apex of the LV as well. So potentially sparing that portion of myocardium from the ischemia that's being experienced by other tissues. And in the setting of PE, there are other proposed mechanisms.
Something that causes an acute, massive increase in PVR, basically, will create bad RV ischemia because of a supply-demand imbalance.
And pulmonary embolism is not the only thing that will cause acute increase in PVR.
Exactly.
Basically.
That's right.
So here we're in the stomach, looking up at the heart with a transgastric short axis view. And so we have LV here, RV over here. And so, of course, this would be the inferior, and this would be the anterior wall, lateral, and septal. Why don't you walk us through why this image is so key to your diagnosis here?
Yeah, so there's two things that hopefully will jump out at you as soon as you look at this. Hopefully the first thing you see is the septal flattening. Our interventricular septum right here is flat, although it's not flat. It's not as bad as it could be. It could be worse. It's definitely completely flat and diastole. It doesn't quite normalize in systole. Would you guys agree?
I would agree with that. Yeah, I think so. And so what sort of information can you extract from that?
When you read about this, when we read about this, even in our guidelines, which I really value, you read this. I don't want to call it nonsense, but you read this nonsense about the words RV pressure and volume overload, and it creates so much confusion in our students. It drives me bananas because it suggests that there are either problems with pressure or volume that create these changes in the septum, and it's important to have an idea what's causing the problem. But what I think we need to remember at the heart, it is the relative pressure in those two chambers that determines the position of the interventricular septum.
Exactly. So if the pressure in the right ventricle here is greater than the pressure in the left ventricle at that point in time, then we're going to see flattening of that septum.
That's exactly right.
And if the pressure in the left ventricle is greater than the right ventricle at that point in time, we're going to see a more rounded septum. Regardless of whether we call it pressure overload or volume overload, at that point in time, it's really, there's a pressure higher in the right ventricle than in the left ventricle if that septum is flattened.
That's right. Also, I know this patient's a little bit hypotensive, which that's a really important thing to keep in mind too. If you are manipulating the left ventricular pressure and the right stays the same, you can make this pressure overload picture come and go without changing the pressure on the right.
And then you mentioned a second finding in this image.
I did.
What else are you taking away from this?
I won't say subtle, but this is really the crux of our discussion in this particular patient. What is it that can help us distinguish between the McConnell sign of PE or all the other things? In this case, obviously, we wonder, has this patient had some sort of coronary event? Do we need to go back to the operating room, or do we need to go somewhere and try to lyse a clot or some other shenanigans? Well, what we're going to look for is other signs of RCA ischemia. And where would we see that here, and do we see it? Roger that. Yes, we see, severe hypokinesis, akinesis. We see bad kinesis of the inferior and probably a little bit of the infroseptal, mid-infroseptal segments here.
And when we're looking at segmental wall motion abnormalities, which is essentially what we're talking about here, we're not looking at so much motion of the tissue itself as we're looking at thickening of that tissue, right?
I think I read that once, yes.
So if I were to take a guy who just came out of the cath lab where they put in a stent or some foreign thrombogenic material in his right coronary artery,
you'd be worried about the other arteries that they didn't put stuff
exactly.
in. Right?
We protected that one.
Yeah.
We already protected
the RCA, it's locked up.
It's
safe.
locked up, yeah. I would wager that this is in-stent thrombosis.
The mortality of acute stent thrombosis is almost twice that of a gunshot wound to the chest in the field. Non-military. But it's like 30 to 60%. The thing about this case is that I find interesting is I saw this guy in a particular clinical setting with this. This guy could have been with you in the ER. He could have gone home a few days later and this exact same combination when he'd been laying around the house, maybe had been immobile, hadn't been doing his PT or cardiac rehab.
Forgot to
and
take his
now,
Plavix that day.
Who knows, exactly. But then he presents now, and now the question's a little bit different. And you're not there with the surgeon in the ICU, doc. You're there having to decide, where does this guy go next?
Absolutely. Let's see what else we got. So here we've got some colorful Doppler over the tricuspid valve. We've just got kind of free flow between the RV and the RAs.
So I think we're seeing a lot in this image. Again, we haven't really talked about this explicitly yet, but we're seeing a wide portion of the RV here, and we can generally not in a color flow setting, more in a B mode setting, do a lot of assessments in terms of how we're going to approach right heart function. And just from an overall perspective of evaluating this case, it might be worth reviewing some of those things. So what we're seeing here, we have right atrium leading into the right ventricle there. We already talked about the portions of the right ventricle that we're seeing. We see tricuspid annulus. And at the tricuspid annulus, there are a few useful measurements that we obtain to evaluate objectively how our right heart is functioning. One of those is TAPSE. Jimmy, can you talk about TAPSE briefly?
Yeah, so it's a long, complicated acronym for a simple concept. It stands for tricuspid annular plane systolic excursion, or otherwise known as TAPSE. And all we're talking about is the distance that tricuspid annulus moves back and forth in space with each contraction and relaxation cycle. Abnormal would be less than 1.7 centimeters of this annulus moving back and forth in space with each contraction. And here we see basically no movement.
I would agree with that.
TAPSE would essentially be zero.
We talked about TAPSE briefly. There are a couple other measures that we can use for right heart function. One of them is a surrogate, not really a surrogate, but an analogous measure to TAPSE in a way, and that is S prime. So we're familiar with using tissue Doppler imaging for a variety of measures, and you can use tissue Doppler imaging along that free wall annulus to measure an S prime, which is the velocity of your myocardium at the annulus moving during systole, and a normal value would be greater than 10. And that is something that you could use as an assessment of right heart function.
Hey Echoholics, Jimmy here again. While we were on the subject of TAPSE and S prime, I just wanted to show you a couple of examples of how to practically do that. We're in an apical 4-chamber view, transthoracic, and we're a little bit focused on the RV so we can see that tricuspid annulus. And then you just want to place your M mode marker right through that free wall tricuspid annulus. Press the M mode button again, and what you'll get is this nice sine wave. Now this sine wave represents the distance that tricuspid annulus is moving back and forth with each contraction and relaxation cycle over time. If we measure a trough to a peak or a peak to a trough, it's going to give us a distance. In TAPSE, anything greater than 1.7 centimeters is considered normal. Anything less than 1.7 centimeters would be considered abnormal. If instead of measuring the distance, we switch our mode over to tissue Doppler settings and place our cursor over that tricuspid annulus, we'll get the velocity of tissue with each contraction and relaxation. The upward deflection is going to be systole, and if that value measures greater than 9.5 centimeters per second, that will be normal. Brian mentioned 10 centimeters, which is the old recommendation from the ASE guidelines. 9.5 would be the most current recommendations. One of the reasons we use TAPSE and S prime is because in studies looking at MRI ejection fraction of the right ventricle, TAPSE and S prime have been the two RV measurements that correlate most closely with RV ejection fraction as determined by MRI. Now back to the podcast.
There are still those of us around in the various areas of cardiovascular medicine that believe that the RV is just a passive conduit, almost a vestigial organ in the heart. It doesn't work that way. The RV has to play the game. You can't push blood past. And if you try to, what you're going to wind up with is our next image, actually.
Now we see that color flow jet has been dramatically reduced in its quality. And so what would that suggest to you, Josh? What are you concerned about now?
Well, basically now we're back at the cardiac arrest stage. This is a PEA. Let me see what you guys think about this. I see this most often, and that's not what's happening here. I see this in over-resuscitation. And I have examples that look just like this in massive resuscitation cases where we let the Belmont go too fast.
So it's essentially excessive preload to the RV, producing acute RV failure, leading to decompensation.
That's right. The RV is part of a fascinating positive feedback loop of dysfunction. Once you begin to tip off the curve of the Starling curve of the RV, you become hypotensive. And if you treat that with more volume, then you become more hypotensive. As the RV becomes ischemic, and the same thing happens in this case, as it becomes ischemic, it begins to fail. It doesn't eject as well. It doesn't fill the LV as well. The LV doesn't eject as well. The systemic pressure falls. As the systemic pressure falls, that doesn't help the RV. It only hurts. You know? So then it's a positive feedback loop where very quickly that ischemic RV then just fails.
Yeah.
And the same thing can happen from volume overload. If you were to hook one of us up to a Belmont and infuse it at its highest rate, we would die of RV failure.
All right, so you had this patient doing poorly, one might say.
One might say.
And so what happened at this point?
At this point, basically, we have, or you have. Let's say that we're in the ER. You've looked at these images and said, we have a problem. Paging Dr. McConnell, wait a second, don't bother coming in. This patient does not need to go to interventional radiology to have them root some clot out of their lungs. We see the McConnell sign. We see this patient dying of RV failure, but we also see a very clear indication of RCA ischemia and a patient we know to be at risk for this. So we go to the operating room. We're not going to cut this vessel out. We're going to bypass it, which is what happens. The patient has an RCA bypass. This is not part of that. This is actually part of our previous discussion where the answer was you have to give this patient a little bit of epi. You give them a little bit of epi because you need to get the RV to contract enough to fill the left ventricle. Here we are actually with a patient who, like, if this were your only image, you'd think, oh, we got problems here. And you do. But this is a patient that has a pulse now.
But compared to the previous couple of images,
there he's smoking. He's looking good.
We're smoking like a Rauch beer.
Yes, we are. And we're able to survive to get to the operating room.
All right, so patient gets another cabbage.
Indeed. Another cabbage
To bypass
after the previous cabbage, after the previous
in-stent
stent.
thrombosis.
Yeah.
And let's see how patient is doing afterwards.
Friend, my colleague, texted me this as I was sort of finishing up dinner, and I have to tell you, I was shocked and surprised. Look how good this guy's doing, basically.
Look how nicely all of that inferior and septal myocardium came back.
He's not dead.
He's not dead.
Apparently, he's still not, like, even as of today, he didn't die. I suffer from this. Sometimes in these stories, the message comes across like, look how good I am. But that's not the message. The message is always, this is easy. If you do this, you will see this. Just like in every other good echo case, the message comes down to, if you don't look, you don't know.
All right, Echoholics. That ends our first episode of Echoholics Anonymous. We covered a lot of ground there, so let's recap and see if we can take away a few learning points. First off, pulse checks and telemetry interpretation, not the best way of knowing what your patient's heart is actually doing during a cardiac arrest scenario. As we saw with Josh's images of VTAC and VFib occurring when we were seeing PEA on the monitor, echo is really going to be the best way of determining cardiac rhythm. Not all RV failure is PE. RV infarct, pulmonary hypertension, ARDS, and even over-resuscitation can cause acute RV failure. In this case, picking up wall motion abnormality helped distinguish between RV infarct and possible PE. Also, TAPSE and S' are useful and relatively easy to perform measurements of RV function. That's it for the inaugural episode of Echoholics Anonymous. Special thanks to Josh Zimmerman for that fascinating case. Music by Big M and the Little Organs. See you next time, Echoholics.